Hello, my name is Ian McCall. This is the overview for Module 6A. Now the module itself is going to look at these things: rosacea and its variants, sebderm, perioral dermatitis. Then it's going to have a look at the dermatoscopy of dots, polygons and structureless areas. And there's a tutorial there in Granomatous Rosacea. You should look at this video, which will give an overview of all the images that are in this module and more, and then have a read through the main material that's here. In the webinar itself, I'm going to concentrate on the erythema, the nature of erythema and rosacea, and some of the new topical therapies for that. I'm going to look at granulomatous rosacea. I'll also look at the differential diagnosis of seborrheic dermatitis. That can be quite interesting. I'm expecting that you've read and looked at the rest of this module on aspects of sebderm. I'm mainly going to deal with the dermatoscopy of polygons in the webinar because of their usefulness in diagnosing lentiginous melanoma. We'll also look at the systemic antifungals, and if you look down the module here just now, you'll see that there is a video here on the systemic antifungals and 3 slides here that look at what I consider are the main aspects of these drugs and questions that you might be asked in the pharmacology exam. And then in the webinar we're also going to look at Granomatous Rosacea because I think it's one that dermatologists see a fair bit of, and so you should be aware of it and how it's going to present. Now, in this module here, looking at rosacea, it's important to recognize the various presentations of rosacea. We're used to the flushing erythematous component, but there's always a bit of sebaceous hyperplasia as well. There isn't comedone formation. There are papules, pustules. There may even be cysts. This lady has the mainly erythematous type. It's probably the most difficult type to deal with, although there is a new gel called brimonidine tartrate gel that's available in the United States. I think it's an alpha-adrenergic drug that causes constriction of blood vessels and can work for 12 to 16 hours with one application. So it's a topical preparation that may be of value further down the track. We'll go into that more in the actual webinar itself. The management of rosacea is very similar to the management of atopic dermatitis acne, I should say, in terms of the medications used, at least the systemic medications. But the other thing about rosacea you've always got to watch is that the skin does tend to be hyperirritable. So there's no point in using some of the retinoids, for instance. They'll just make the situation worse, and there's no real indication because the primary pathology in rosacea isn't the microcomedone, and that's mainly what the topical retinoids are used for in acne. This was just a picture of granulomatous rosacea, but you'll see her again and a variety of other images of her in the actual webinar. It's a more intractable type of rosacea, this, and quite a distinctive type clinically. Read up a bit about Rhinophyma. This is the sebaceous hyperplasia element to rosacea. And remember that it can affect other areas than the nose. This guy's got a bit in his chin here as well. This guy's got really extensive involvement of his forehead. You can get involvement of the ears, the earlobes. It's an unusual presentation, obviously, when it presents like that. Perioral dermatitis, you should know a little bit about. Some of the condition can occur in children. Again, it may be due to topical steroid use in that circumstance, but there's other circumstances where it comes up in children and it's not due to topical steroids. There are some women where overuse of fairly thick occluding cosmetics will give rise to perioral dermatitis. We see this a lot, mainly, as I say, because of the overuse of a fluorinated steroid on the face. So know a bit about it, know how to recognize it. Always look for that little bit of sparing that's between the involved area and the vermilion border. It's quite a useful way of distinguishing it. Sebderm we'll go into. It's a yeast infection. It primarily involves the scalp, the eyebrows, the area in between the eyebrows. You'll often see scale there. A bit of blepharitis associated with seborrheic dermatitis, which reminds me, I should have mentioned a little bit about ocular rosacea. Read up a little bit about ocular rosacea as well, because there's a fair number of rosacea patients who present to the eye specialist with ocular involvement and relatively minor skin involvement. What else? Yeah, in sebderm, consider the use also of pimecrolimus or tacrolimus rather than a topical steroid to suppress some of the inflammation, if you're not going to be using a topical antifungal to deal with it. In some cases of severe sebderm, need a nasal like ketoconazole. There's a little bit in here on flushing as well. And remember, severe facial flushing may be a feature of the carcinoid syndrome. And if it does, it's usually very extensive, and not only does it involve the face, it'll involve the neck and the chest, and it may be multicolored, and it may last half an hour before it goes, unlike the more minor flushing that you'll get with rosacea itself. So be on the lookout for that particular condition. Read up a little bit about it. It's really quite rare. You usually have to measure 5-hydroxyindole acetic acid levels in the urine to make the diagnosis of this particular tumor. Now, in terms of the dermatoscopy things we're going to look at dots, but I'll go over them in a bit more detail in the actual webinar. Dots, the main ones you're going to look at are the gray dots. And the gray dots are important because of these differentials of LPLK, pigmented solar keratosis, pigmented IEC, especially if the dots are in lines. And they may not just be gray, they may be brown dots there. In that, you'll see here that they're listed there as the commonest of the brown dots, especially in lines. And red dots, bones disease, inflammatory skin disease, particularly psoriasis, particularly in the lower legs, and clear cell acanthoma will give you red dots, often dots in lines with this as well, the clear cell acanthoma. So, go through this and the video up there on dots and the different types. The grey dots, the brown dots, and the pink dots. This, by the way, was the picture of the clear cell acanthoma. And it's like a little necklace. Sometimes the way the string of pearls sort of sign, they'll call it for the dots in lines like that. In a clear cell acanthoma, often presents as a pink lesion like this. Sometimes in the trunk, sometimes in the lower leg. Histologically, by the way, it's a variant of seborrheic keratosis with clear cells in the epidermis. From memory, I think the clear cells have glycogen in them. We are going to talk about polygons in the actual webinar, so I won't go into them in great detail, except to say that they're angulated, 3 to 5-sided angulated shapes, and you'll see them particularly in melanoma in situ. You can see them sometimes in lichen planus like keratosis, and in pigmented solar keratosis you'll see them. They're a good indicator of in situ melanoma of the face, particularly in the back. I mean, it's a lot of these elderly patients we see with extensive diffuse pigmented areas. Some maybe just flat seb-Ks. If you see polygons within them, then consider that they may be melanoma in situ. Do that in more detail later. And the last of the dermatoscopy was structureless things. Now, let's have a quick look at this. Peripheral structureless areas can be a feature of melanoma. So it's one of the markers, in fact, of melanoma. Black structureless areas, we said old hemorrhage or thrombosed, occasionally nevus and melanoma, and subcase can be black structureless, the melanoacanthoma, that version that has dendrites, has a lot of melanocytes higher up in the epidermis, but a lot of dendrites and the things as black as the ace of spades, the melanoacanthoma. Brown peripheral structureless, BCC, that light brown peripheral structureless, you'll see that as a feature of basal cell skin cancer. Blue structureless, particularly the blue nevus, foreign body, old hemorrhage, but BCC and melanoma as well. If they're smaller, they'll be blue globules or clods. Red structures is usually fresh hemorrhage, blue-white, melanoma, blue nevus. Some thick seb-Ks can be really blue-white structureless as well. White, yellow, or orange structureless, we've said seb-Ks, keratoacanthomas, and white structureless, the dermatofibroma in the center with all that collagen, perhaps a scaromorphic, BCC, mollusca, accessory nipple. Some sebaceous look white rather than yellow and can appear to be white structureless, but usually they're sort of white clods, these. So, have a little look at the rest, listen to the video, and have a look at some of these images here to go through the different types of structureless and what they might mean. This one here, from memory, I think is a picture of Kaposi's, yeah, non-HIV type. Some white lines here, but really pink to red structureless. Some white septae in between, but really it was a Kaposi's sarcoma. What have we got for Granomatous Rosacea? This kid shows some of the features of it. Usually you're going to get your papules or papulovesicular lesions are going to be on the cheeks and on the extensor aspects of the arms, like this, or the legs, and they almost look like papulovesicular here, but they don't exactly weep or break onto the surface. But it's the location. The trunk's generally clear, and it can be a variety of viruses that can cause Granomatous Rosacea. But again, I'll show you a lot more images in the webinar, and we'll discuss a bit about the viruses that we see in this part of the world and whether we do any tests and how long it takes for it to in fact settle. There are a few, there's another little thing there on the skin rashes of infectious mononucleosis. Always remember the one where someone gives them ampicillin, they just get the generalized ampicillin rash. They're not necessarily allergic to other penicillins if they get that rash. That's an important point. And remember the Epstein-Barr virus being involved in oral hairy leukoplakia as well. We'll try and have some images of that up. This was the video on the systemic antifungals. I won't go into that. And then there were a couple of cases that I hope we have time to chat about in the webinar itself. This is contact vitiligo, and I think this was erythrokeratoderma variabilis. The latter, this one we don't see an awful lot. I'll try and get some other good images of that and get them up for the actual webinar itself. So, if you get a chance, look through these things before Monday night's session, especially the videos. You'll get most of the information out of those, and we'll cover these particular topics in the webinar itself. Thanks very much.